Well, it's proper that I should go at the end, and I'll try and wrap this up because I know everybody's been sitting for a while. So when all of those other things don't work, then there are some interventional techniques. Now, these techniques are not suitable for everybody, but I'm going to show you why we can do this, and hopefully elucidate for everyone when it's appropriate. One of the things that's made interventional radiology, which is a way of using image guidance to do surgical type procedures to patients possible, is the growth in our ability to see what we need to see to do the procedures. And that comes with unbelievable imaging that we're able to do nowadays. We have real-time CT, we have all kinds of reconstruction, so we can basically get pictures of the body in exquisite detail. We're also able to see, this is an example of CT fluoroscopy, so you can see we're putting a needle targeting a very small mass in this patient in order to be able to treat it, and we can do that avoiding the surrounding structures. This is the bottom of the liver, this is a piece of the bowel. All of these techniques rely on accurate positioning of whatever our device is to be effective. This is an example of three-dimensional imaging that we can do. We can do this with CT, we can do this with MR. We can take images that you have with ultrasound and fuse it with a CT or with an MR image. And so this allows us to really be able to target accurately tumors within the body so that they can be treated without surgery, basically with a very tiny incision, and with most of our tools are comparable to a needle. So this is just an example of how we can fuse different studies. This is a patient who had a recurrent lung cancer, and this is at what we call the apex, at the top of one of the lungs. When you do a CT, all we see is a lot of stuff that's the same density. It doesn't discriminate for us what's tumor, what's scar, tissue related to the surgery. Well, if the patient has a PET scan and you can see that there's a metabolically active area within this gray part of the CT scan, that tells us that that's an area of recurrent tumor. We can fuse the CT image. CT is often what we use for guidance, but we can fuse the CT image with the PET image, or we even have a room where we can do interventional procedures that are guided with PET CT, and I'm going to show you one of those in a minute. There are no graphs here. There's no data. This is these techniques are specifically indicated for a rather small subset of patients. We don't see hundreds of patients here with GI stromal tumor to begin with. And once we get down to the patients where this is applicable, which has to do with location and number of the tumors, I don't have any data. I can only show you some applications. So there's another thing that we can do to treat GI stromal tumors. They tend to be very vascular, and so one of the ways of killing tumors is to actually plug up the blood supply. So you can take a catheter and put it into the blood vessel supplying the tumor and inject very small particles. So that's called embolization. And then ablation is the thing that I was showing, all the devices that look sort of like needles. And ablation basically means to kill the tumor while it's within the body using either thermal ablation, which heats up the tumor and kills it with heat, which is radio frequency and cryo and microwave, or to kill it with cold by freezing the tissue, which is cryoablation. And then there's a new way of killing tumors that is not thermal at all, which has some potential benefits for not hurting the surrounding structures, and that's called IRE, or irreversible electroporation, which is a method where using, a needle-like probe, you basically open up the pores of the cells, and they die by losing their intracellular contents. Very simplified explanation. So arterial embolization we use for hypervascular tumors, which just tumors are. We inject these microspheres, we plug up the terminal vessels in the tumor, and the idea is that that causes ischemia, and the ischemia results in tumor cell death. Often we combine these methods in GI stromal tumor, and I'll show you some cases that illustrate why. So percutaneous ablation devitalizes the tumor by using, as I said, either heat or cold or irreversible electroporation. So here's an example of a patient who has a scan that on the left side that's from November of 2005. This is the liver, and the liver is supposed to look all this nicely uniform gray color. Here's the patient about 6 months later, and all of a sudden you see this thing in the liver, and this is a fairly typical imaging appearance for GIST tumor when it spreads to the liver. The patient is started on Gleevec, and 5 months later, where you saw this rim of what looked like viable tumor with a darker area in the middle, this is usually the enhancing part is the viable tumor. Now the thing looks all dark. So this is good. So the patient stays on Gleevec for a couple of years, and then the Gleevec is stopped. Well, you see what happens. I mean, we sort of touched on what happens, how long you're on it, what happens when you stop it. And this patient had an explosion of the disease in the liver that looked like that. The patient was put back on Gleevec, and again, there was a response with most of the tumor turning dark. The patient recurred 3 years later, 2.5 years later, while on Gleevec, and the way that we image or we assess for recurrence is most of the thing is shrinking and it's turning darker, which means dead tumor. But within that dead tumor, you see this, which is a little nodule of mural enhancement, which is indicative of recurrence. So the patient this is the PET scan, same patient, so this is that supposed recurrence, and indeed it is PET avid, or it's very metabolically active. So this is an ablation device. This is a microwave ablation. This is a thermocouple, and this is the actual ablation device. And you can see if you sort of match up the geometry of the tumor with the little nodule recurrence that this is right through the recurrent nodule. So this is the patient's PET, again, before they were treated, the PET scan, and this is the patient's PET scan afterwards. So a couple of months afterwards, the tumor appears to have been completely eradicated. Now, we're going into December of 2011, so we go from this metabolically inactive lesion. Now you start to see some activity. It's on the other side of the lesion. It's on the back of the lesion, but you can see that it's becoming metabolically active. So in this case, it was also it wasn't exactly a simple nodule. It was a little more complex in shape. Anyway, the patient had first an arteriogram. This is an injection of the blood vessels that go to the liver. And what I can see and can point out to you is you see this area, the small nodular area where there's increased what we call vascularity. There's a little tumor blush, and that corresponds to this area of the tumor. This is a CT that's done immediately after the embolization. And what happens is because the blood vessels are plugged up, and we do this by injecting contrast into the arteries, the contrast is retained in the area of tumor, and it gives us a very good target. So in addition to giving us a good target, it provides a way of killing the tumor, so to speak, in two ways. And so here the tumor is targeted again with a microwave device. And here's the patient more than a year after their treatment, and they've remained quiescent with no evidence of recurrent disease. So the thing that I labeled this with is minimally invasive treatment plus Gleevec, basically bought 7 years for this patient to date. Here's another patient who had been treated with Gleevec, and again, the liver lesions predominantly become cystic, very low density with no enhancing tumor, but you can see there was some rim and mural nodular enhancement, meaning viable tumor. This patient was treated with radiofrequency ablation a couple weeks later, and you can imagine how this is targeting that area of the tumor. And this is how the patient looked 2 months after treatment with no evidence of enhancement in that lesion. Patient had a second lesion in the left side of the liver, right here, this enhancing nodule in a background of necrosis, what we call necrosis, and another ablation was done. In this case, again, you see two needle devices. This is the actual ablation device, and this is a needle that we use to inject saline, because if you notice, this structure here is the stomach, and the stomach is right next to the thing that we're trying to ablate, and if we get a good zone of ablation plus a margin, basically the worry is that we'll burn the stomach. So our imaging equipment allows us to move organs or away from our site of target in order to protect them from getting burned or frozen, whatever we're doing. And then again, this is a couple months later, the repeat CT, and now instead of having this nodule of enhancement, you have just a big area of ablation. And the other area also stayed relatively well ablated. However, 1 year later, we see a little bit of enhancement here, and we see quite a bit of enhancement here. So this time, we do the embolization. Again, this is injection of contrast into the artery that goes to the liver. And on the delayed images, you can see a tumor blush here, which is that lesion on the right side of the patient's liver, and another tumor blush here. And so those are both areas of tumor. After we put a catheter selectively into the vessel supplying those lesions, this is the follow-up. This is the arteriogram pre, and you can see all the vessels going out into the liver, and this is post. So you can see that the vessels up here are missing because they've been injected with these microspheres to plug them up, and the vessels over here where there's that blush are also missing for a similar reason. We then do a follow-up CT. The lesions are bright because they've been targeted with ablation. We then ablate both of them, and this is how the patient looked the following year, about 3 months later, with big ablation artifacts in both places. And this is the patient in 2011. And I wrote minimally invasive therapy plus Gleevec equals 4 years because I happened to have looked at the patient's MRI just before I came over here, and there's still no evidence of disease. But I also put that it's not entirely accurate because there was a little surgery involved in the meantime as well, but not on these lesions. But it just goes to show how we can all work together to treat these recurrences and to maintain or do our best to maintain disease-free intervals. It's a partnership between the people who give the medicines, the people who do the surgery, and us who can take care of these small recurrences. So as I said, it's a complement. Its applicability is limited. If you have 10 lesions, we can't treat 10 lesions because we end up eradicating your entire liver or wherever the lesions might be. It's also limited by location. If you have a tumor sitting in a very critical location, like deep in the pelvis where it's sitting right on the nerve, then we can't, at this point, we can't do that, although IRE has some potential applicability. We do use general anesthesia, so when we say it's minimally invasive, it's not like coming in and having a filling or something. Most of the procedures are done with general anesthesia, but on the other hand, they're often performed as an outpatient basis, so the patient goes home the same day. And I think that there's very little effect from the procedures on the quality of life in terms of within a couple of days you've recovered from the procedure and can go about normal activities. Anyway, this is what interventional radiology does, and I hope you enjoyed the fact that at least it had a lot of pictures.